Yes, yes. Sir.
Let us fix as 10th and 17th next month.
Yes, sir.
So I will fix it here. 10th of October, 5 to 6 p.m. Okay.
Yes, sir.
And which module? 10th for.
This will be the 5th module, sir. Complications of diabetes, I think. I'll have to see in.
Anyway, module. But we have finished this 4th for everybody by these two.
Yes, sir.
So module 5 will be on, let us say, 10th. Okay. Then 17th again will be module 5, right?
Yes, sir. Yes, sir.
B, C. Module.
Sir, I think we are live now.
Okay.
Yes. So we'll just wait, sir, for 2-3 minutes and we'll start sharp by 5.
Okay. We still have 3 minutes.
Yes. So due to some technical glitch, sir, I'm not able to switch on my camera. Some technical glitch are there.
Sure.
Good evening, all the respected doctors and our colleagues. At the outset, I, Dev Tyagi, on behalf of Mankind Pharma Limited, welcome you all for the 5th module of NDEC Advanced course. The topic of today's module is pharmacological management of diabetes, that is injectable. And we have with us our course director, Dr. Prasanna Kumar sir, to speak up on the same. So I would request Dr. Prasanna Kumar sir to start with the scientific proceedings.
Thank you. Good afternoon, everybody. Today we'll be talking about the injectable pharmacotherapy. As you know, the most important management of diabetes is always insulin. So today we are going to talk insulin in the management of diabetes. This is the conflict of interest statement from my point of view. I don't have any. Then this is my disclaimer. Now today we are going to learn 5 points. What is it? How to initiate insulin. When you say insulin, you will always ask why insulin, how insulin, when insulin, which insulin we should start. And next thing is, it is not just enough to start insulin, you have to intensify it to reach the goal. So what's our goal? Next important thing is, it's not like tablet, you just swallow a tablet and then go to doctor 3 months later. Monitoring diabetes is very, very important aspect of initiation of insulin and intensification. What are the various insulin delivery system? And more important, what is hypoglycemia? How to manage hypoglycemia when you are on insulin. So the agenda of what I'm going to set up today is insulin initiation. What are the clinical consideration? When we should start, how we should start. How to continue insulin care, and what are the clinical consideration. And insulin administration, which is acceptable, adaptable, and affordable by the patient as such. Because unlike in the past, it is not just syringe. From syringe to pump, there are various things. So let us look at indication. When to start insulin initiation. One is temporary, and the second thing is long-term initiation of insulin. And there are two types, absolute indications and relative indications. So both are there, absolute as well as relative indications for it. Diabetes is not controlled with maximum dose of antibiotic. That is the commonest indication of insulin. You know, in pregnancy it may be temporary. During stress it may be temporary. Now during COVID, patient is admitted to hospital with COVID. When they give steroids, it may be temporary. So the permanent usually is when the patient is on maximum oral antibiotics. What is the maximum? 3. Many patients use 4. Many doctors prescribe 5. It is not true. So you use maximum dose of 3 oral antibiotic. A1C is still above 7 or the target, that is the indication. When do you start insulin? From day 1? Sorry, that is type 1 diabetes. So as you know, type 1 diabetes is absolute insulin deficiency from day 1, not 1 or 2, but 3 or 4 basal bolus. That is the insulin, that is the regime from day 1, type 1. When the patient is admitted to hospital, diabetic ketoacidosis, hyperosmolar, hyperglycemic, non-ketotic states or syndromes, again, situation, and type 2 diabetes during periods of physiological stress, as I told you, the temporary insulin solution, and pre-gestation diabetes. Somebody is well controlled with tablet, then we say, sorry, you cannot take this when you're pregnant. Let me change over to insulin, control diabetes. Then only you can conceive. A1C should be 6. Gestational diabetes, diabetes that appears first time during pregnancy. So till delivery, take insulin. Afterwards, we may consider others. And let us say a patient comes with fresh diabetes. Today is detected A1C is 10, 11, 12, 13, 14, 15. Now we have seen even 20 also. Then you say, look here, your blood sugar is very high. So I will insulin in a month or 2. I'll control with insulin. Then slowly I will introduce tablet, increase it. So ultimately I'm going to withdraw insulin. So even at the beginning of the onset of diabetes and even at the end of maximum oral antidiabetic. Then if the patient has renal failure, maculopathy, proximal muscle weakness, peripheral neuropathy, these are some of the relative indications. So when you see all these ones, so there are long-term, short-term, temporary, permanent, absolute or relative. Sometimes it is even choice like that you can. The question is, when we start insulin, what are the challenges that we face? As you see in this one, non-compliant. This doctor, I cannot take insulin. I am afraid of thing because I don't know how to take insulin and I am not sure about it. Concerned about risk of hypoglycemia gain weight. Patients say, I've heard that if I take insulin, I'll put on weight. I don't want to take insulin. And I have also heard that it can cause low sugar. I am elderly, I am old, I am alone, I cannot make. So these are the factors, the patient's factors and patient resistance. Patient says, I heard that insulin is the last resort. After that, I'll get into complication. Insulin will cause renal failure. So many things. So patient resistance is the one. Patient's non-cooperation. These are some of the things. 27% of the persons with type 2 diabetes use insulin therapy, but less than one half achieve the recommended A1C of 7%. So if we see 1 in 5, 1 in 4 patients need insulin, but half of those who are taking insulin have A1C below 7. Most of them are 7.5, 8, 9. I've seen in type 1 and 11 also. We have advised them 4 times insulin, still they come back with 11%. Is the compliance poor, or they don't know how to adjust the dose? This is the picture which we see today, though it was published in Diabetic Age 2004. Now, what are the treatment strategy when we start diabetes treatment with insulin? One, what HbA1c do we start insulin? 7, 7.5, 8 or 9? And whether we should target fasting blood sugar or postprandial. The answer is we should take everything. We should bring down HbA1c target, whatever you have put for that patient, 6.5 or 7, 7.5, whatever it is. So check, see that fasting blood sugar is normal, normally 70 to 100. At least if we keep a target 90 to 120, that is good. Postprandial target is anywhere between 140 to 180. So you have to target both fasting, postprandial, HbA1c. All of them should reach the target. That is very important. Now, all of us were happy doing urine sugar 30, 40 years back. Then we were doing blood sugar. Then we were doing fasting and postprandial. Then HbA1c. Today, we are not happy with just HbA1c being 7 because, as you know, sometimes it is the blood sugar is 70, sometimes it is 200, average maybe not. So standard glycemic parameters like blood sugar, A1c, glycemic variability can be a future target parameter for ideal glycemic control. What is glycemic variability? As you know, within a day, blood sugar will vary between 60 to 200. Recent studies have shown that glycemic variability could be the cause of micro, to some extent, macrovascular diabetes complications, and these complications may be decreased by minimizing the glycemic variability. There are 3 terms you should understand: time in range, time below range, time above range. The time in range is, suppose I fix 70 to 140 or 160. So 70% of the time in 24 hours, the blood sugar should be between 70 to 140, 160, whatever it is. Time below range, less than 5% in the day, the blood sugar should be less than 70 in this patient. Time above range, less than 20% in 24 hours, the blood sugar should be above 140 or 160, 180. Depending on the patient, we can fix it as such. So, what is the goal of insulin therapy? Why do we give insulin? How we give? What we are trying to know, body physiologically, body produces insulin throughout the day, and half-life is 4 minutes. When you take food, suddenly insulin comes up like that. There is phase 1 and phase 2. We are trying to duplicate how the pancreas works in releasing insulin for someone who doesn't have diabetes. So how the insulin release occurs in a non-diabetic, same way we are trying to give insulin. But definitely it is not possible 100% to duplicate that. We are trying to see as physiological as possible. So optimize diabetes management, achieve euglycemia. Why? To prevent complication. So this is the one. What is the goal? What is the objective? When to start insulin therapy, which insulin, doses, delivery options, syringe, pen and pump, and how to train the patient or educate for this insulin therapy. So these are the 5 questions which are important when we say insulin: why, when, how, which insulin, how much of insulin. Now, how to give insulin? There are many methods of giving insulin. One is basal insulin. As you know, today we have basal insulin, which works 12 hours, 18 hours, 24 hours, even 36 hours. NPH works 12 hours. Glargine works about 18 to 22 hours. And Degludec works for 36 hours. Then there is short-acting prandial insulin. These prandial insulin work 4 to 6 hours. They are given before breakfast, before lunch, before dinner, preferably 3 times. Then you have pre-mixed insulin. It may be various mix of regular plus NPH. So pre-mixed insulin are given twice a day. Then split mixed insulin, whether you give once, twice, or thrice. The ultimate is basal bolus insulin. Basal bolus is 3 times boluses you give before breakfast, lunch, and dinner. And 1 basal insulin you can give. So 24 hours good control. That is the most physiological way of giving it. Coming to devices, there are syringes, then there are pens, and there are insulin pumps also. Now, which insulin? Next, when insulin? So one is early initiation of insulin. That means earlier you start. What do you call earlier? When you are using 3 oral antibiotics, still HbA1c is more than 7.5 two occasions. Then you start early initiation of insulin. So when you have already reached 3 doses, metformin, I'm giving you DPP for SGLT2 maximum dose. Tell the patient, look here, from today I'm giving you maximum dose. You come back after 3 months. If HbA1c is more than 7.5, you may need insulin next time. So even one visit, put it in the mind of the patient that you may have to start insulin because you are given maximum dose. Then patient realizes if I don't control well with diet, exercise, compliance to medication, probably doctor may advise insulin. So what are the barriers to insulin initiation? Then what is inertia? The inertia from the patient's point of view, inertia from the physician's point of view. The most important thing is which insulin to start. Now, what is this early initiation of insulin? Early intensive insulin therapy in patients with newly diagnosed type 2 diabetes has favorable outcomes on recovery, maintenance of beta cell function, and protect glycemic remission compared to treatment with oral anti-diabetic agents. So all these studies, because the first insulin therapy was done by Chinese way back in 1960, this is what Jiang Ping Wang and all have published. What they did, they give multiple doses or insulin pump for 2 weeks, and then they followed up patient, they followed that the beta cell was preserved. Now there are so many other studies which to show early initiation and intensive treatment will protect the beta cell, what is known as glucose. There are challenges from doctor's point of view. Patient, I don't want to take because there's no tablet and the fear of needle. Then insulin reviewed as a threat by patient and physician. So this is how patient feels that insulin is a threat for them, both for physician and patient. Then hypoglycemia. Many times patient feels that I'm alone, I cannot manage this because of hypoglycemia, I am worried about it. So these are some of the issues when patient thinks that if I use insulin, then it will be a problem. That is why patients are also scared of using the insulin also. Then if you look at doctor's point of view, that discomfort with insulin, lack of knowledge of experience. Why this insulin model is very popular? Doctor, I'm a family physician. I have never used insulin. This was 30 years back. Today, there is no discomfort with insulin. Knowledge and experience of family physician, everybody is good. Most important is lack of time. Because he says, if I start insulin, the patient will ask hundreds of questions. He has to spend a lot of time. And whereas if I prescribe one more tablet, patient will, all right, it's not controlled, take one more tablet, come back. Honest, the physician's inertia, why they don't start insulin is lack of time. When there are 30 patients, if you talk telling about insulin, patient will ask 50 questions. You have to ask him, convince him how to take insulin, when to take insulin, why you should take insulin. So that is why I don't have time. Let me prescribe one more tablet and postpone. Like this, the physician inertia goes on. Another important thing is fear of losing patient. No, doctor, if you are starting insulin, I will never start. And doctor may be worried this patient may go to another doctor and he may not come back. So these are the real blocks or inertia on the point from the point of view of patient and physician, why insulin is not started most often at the appropriate time or early initiation. Now, these are some of the tips I want to give you based on my 4 decades of experience. Discuss possibility of insulin therapy well in advance when it needs to be implemented. So patients have time to explore their fears and obtain information. Once you say now HbA1c 8, I will start. No, doctor, it has always been good. This time because of COVID I got, daughter's marriage was there, festival was there. So they give all sorts of excuses. That is why. So even 1 or 2 visits before you think patient should be on insulin, put in his mind that I have put you on maximum tablet. It is not working. We may have to consider insulin in the next visit if it is not controlled. So patient knows, oh, he may start insulin because my sugar is high. Check compliance with diet, exercise, oral medication before initiating. You tell them blood sugar is high, we have to start insulin. So doctor, I forgot to tell you, I was busy. I have not done exercise last 1 month because of COVID rainy season. My daughter's marriage was there. I have taken sweet. I forgot to take tablets. I was very busy. Give me 3 months time. I will do diet, exercise, come back. So please check compliance of diet, exercise, all medication. We are convinced he is 100% following diet, he is following exercise, and he is taking medicine. In spite of that, HbA1c is more than 7, then you may consider insulin. Again, this fear of need, consider use of pens that do not wear syringes. Show me insulin pen, open it and say, look here, the needle is so small, so thin, it is hardly any pain at all. Even it is less painful than a mosquito bite. So if you take insulin through the pen, it will not hurt you. So once you offer insulin pen rather than syringes, you'll convince, yes, it is less painful, I can take it. Most important, educate patients regarding benefits of insulin. Doctor, why can't I take? I have taken 5 years, 10 years, 15 years. Now at 75 years, you want to start insulin. And I'm afraid of hypoglycemia because I am old, I am alone, I cannot manage. So tell him, what are the benefits? Tablet has to go and kick pancreas, and pancreas has to stimulate beta cell, and that insulin comes. Now we have been stimulating this pancreas beta cell for 5 years, 10 years. It is exhausted. Tablet do not work like insulin. And now that insulin is exhausted, it will not produce insulin. You have to take insulin from outside. That is only by injectable. There's no oral insulin right now. Then hypoglycemia, nothing to worry. I will tell you what are the symptoms of hypoglycemia, how to manage. You have glucose with you, and you have glucose meter with you. Check blood sugar. Anytime you feel these symptoms, sweating, tremor, anxiety, drowsiness, check blood sugar. If it is less than 70, take about 10 grams to 20 grams of glucose, and 10 minutes later, blood sugar will go up. This is nothing to worry. You know such very serious side effects of hypoglycemia. And never use insulin as a threat. Your diabetes is not controlled. I'm going to put you on insulin. So never use insulin as a threat to patient. You should convince him, educate him how insulin is better than tablet so that good blood sugar control is achieved, complications are less, quality of life is better, even quantity of life is better. Now, when we say insulin therapy, we have to look at 2-3 patients. One is type 1, type 2, and gestational diabetes, or even secondary diabetes. Type 1 diabetes, insulin is a must. Gestational diabetes, most of them need insulin. Secondary diabetes also need insulin. So the goal in type 1 diabetes is associated with complex insulin regime. Always in type 1 diabetes, use basal bolus. Never use premixed insulin. Please give 3 doses of bolus insulin before breakfast, lunch, and dinner. 1 basal insulin. This is the most physiological way of managing insulin in type 1. The goal is to achieve better control of glucose level through accurate adjustment of insulin dose. This is important. Let patient have good food because the child has to grow. Adjust insulin accordingly. In type 2 diabetes, you have a simple regime. When you start most often, start with only basal insulin alone. Once insulin. If the fasting, postpone you will take care. Or use premixed insulin once, maximum twice a day. You don't basal bolus in all type 2, hardly less than 5 or 6% need basal bolus. Goal would be to assess behavioral changes, reduce calorie, carbohydrate intake, increase physical activity, so that we can give minimum dose of insulin as such. This is what we see, mean HbA1c from beginning. The ADA goal is about 7%. Patients start here, sulfonylurea, metformin, combination goes up to 9.6, then initiation of insulin. By the time insulin is initiated, patient often had a disease of more than 10 to 15 years and have already developed complications. Failure to advance therapy when recommended may delay insulin therapy up to 8 years. In India, insulin therapy initiated only when the A1C levels had deteriorated further around 8-9%. At least what I urge, when 2 consecutive times types of oral antidiabetic more than 7.5, please initiate insulin. Whereas that is not true, because in these cases, many times it may be much higher than that, as you see here. Is insulin in Indians, are we different? Is there greater insulin resistance compared to the Caucasian population? Higher insulin levels due to glucose rate and other bases? strong family aggregation with high prevalence among first-degree relatives and vertical transmission through 2 or 3 generations. So these are the reasons why the insulin in Indians is slightly different from others. As you know, diabetes occurs 1 decade earlier in Indians compared to, or even Asians, South Asians compared to not the, the Western population. So also they will use insulin much earlier. They need insulin much earlier than others. Diabetes also develops at a younger age, as I told you. That's why they need insulin very early rather than late. This is what is known as where you see north, south, east, west. As you can see, 3,000, 8,000, 7,700, 4,600 patients. The average HbA1c that insulin was started, North India was 9.2, South 9.3, East 9.44. And the postprandial blood sugar and fasting blood sugar was 194, 284. You should have started 7.5 at least, or fasting above 140, postprandial above 190. 140, 180, 7.5. Whereas by and large, this is 194, 285, 9.2. So duration of diabetes is 8 years. Usually by 8 years, 80% of the patient need insulin. By 10 years, 90% of them need insulin. This is the truth what you see. Now, before we start insulin, we should know what are the different types of insulin. You may get, what is it? There are so many types of insulin. How to choose insulin? Very simple. All of you know NPH insulin. Start working within few minutes and then see peak action is 4 to 12 hours and the duration of action can be 24 hours. Premix insulin starts working like in half an hour and works for 2 to 8 hours up to 24 hours. Then you have got premix 50-50. Glargine, there is no peak. Peakless insulin starts working in 2 to 4 hours and works up to 24 hours. Datimer starts working in 2 hours. Again, there is no. So glargine datimers are long-acting, no peak, and both of them work 16 to 24 hours. In fact, these are the one. Then you see insulin analog mixture, 25, 75, 50, 50, 30, 70, and all. All of them have the same. Maybe 15, 20 minutes they start working, and their peak action is 1 to 4 hours, and up to 24 hours they get. Regular insulin has a starting action within 20 to 30 minutes, works are up to 2 to 3 hours. Maximum duration is 8 hours. And Lispro is again short-acting insulin. Degludec is again another peak insulin. Glargine, Datimer, and Degludec. And action starts within 1 to 2 hours, no peak. And it was nearly 36 to. And Idagasp is the other one, which is a combination of insulin message. So there are many types of insulin. You can choose which is practical for your patient, affordable, available, accessible. So many types are there. There is nothing like one size that fits all, depending on patient socioeconomic status, affordability, availability, because all these insulin may not be available in a rural setup. Discuss with the patient why this insulin, syringe or pen, cost of insulin therapy per day, per month, and patient says, yes, doctor, if this is the one I can afford, yes. So these are the ones which I put. These are the generic aspart, Lispro, Glulysin are the 3 insulin analogs which are short-acting. Then regular insulin, which is the most economical, NPH, which is the most economical, then long-acting deglutide premixed are the ones which have got both the NPH and regular are here. Co-formulation, this is the only co-formulation. Both are analog, that is deglutide and aspart. And these are the trade names of different types of insulin, which you already know. So this is to compile all the type of insulin which are available. So as I told you, NPH insulin onset within 1 to 2 hours, peak is 5 to 7 hours, and maximum 13 to 18 hours. So you may have to take in most of the cases twice a day because of 12 to 16 hours. Glargine onset 1 to 2 hours, there is no peak, works 20 to 30, once a day is enough. Datimer also same, works for 24 hours. These are the different insulin. If you see aspart, now we have got PS, that is known as fast-acting aspart. The curve is even sharper and declining. We want insulin which quickly gets absorbed, quickly disappears in the body, so there is no hypoglycemia lead. Whereas regular insulin is a slow curve, so you may get late hypoglycemia after 6 to 8 hours. NPH, less chances of hypoglycemia because it's a smooth curve here. Datimer, as you can see, 20 hours, whereas glargine you see 24 hours, and degludec also same way. This is how you see one insulin, that is normal pancreas, which is very fast, half-life is 4 minutes. Regular insulin, if you see how it is like this. Then you see rapid-acting insulin analogs. Then you see fast-acting insulin, what I told you, very fast-acting aspart as such. Then you have this ida gas, which has got 30% of the aspart, which acts up to 8 hours. Then it is long-acting 24, even 36 to 42 hours. This is one where both the analogs are used. Glargine has a pH of low pH of acidic. You can't combine it with the other insulin. Here, both this aspart as well as the degludec have the same pH of 7.5. That's why it is the only co-formulation available. So even one dose, if we can see, almost majority of the day you can control diabetes with this degludec ida gas. Now, what are the rapid-acting insulin analogs that when given just before meal? This is the advantage. Whereas when you use regular and NPH, you have to give 15-20 minutes before food. Especially in infants, they take a meal or they don't eat it or they vomit as such. So that is why you can give this insulin even at the start of the meal or even after 20 minutes after starting a meal. So child has taken 1 cup of rice, now I can give insulin. Long tail of action, more rapid declining during the first 30-60 minutes. Quick acting, less hypoglycemia. Useful in basal bolus regime, can be combined with glargine, datamar, degludec. But you cannot mix in the same syringe. But glargine is given separately and fast acting, this insulin analog are given separately. Whereas degludec can be combined as I showed you in this co-formulation. And this rapid acting insulin analog, regular insulin, they all can be given in insulin pump. None of the long-acting insulin, glargine, datamar, insulin pump because given 24 hours. Now, you start with basal insulin, pre-mixed insulin. What is the different insulin regime that is there? Basal insulin means long-acting NPH or even glargine or degludec, effective, safe in type 2, uncontrolled equivalent anti-diabetic. Individuals may not achieve glycemic target because it will not take care of postprandial sugar. Regime does not offer optimal control of postprandial hyperglycemia. Basal plus or basal bolus requires multiple dose. Patient may not accept. More complicated for support and teaching patient. Problems of hypoglycemia, weight gain or more. Needs full patient motivation. If somebody has to take 3 doses, 4 doses every day throughout life, it needs tremendous amount of motivation. And premixed insulin is relatively easy. I know most of you use premixed insulin, even in also most popular, offers best postprandial control, more effective in lowering A1C than basal insulin, improved compliance. Doctor, once a day premix, twice a day premix test, 3 times, 4 times not possible. This is what patient says. So whether to start basal or premix. When you start basal insulin, simple, take 1 injection, 10 units. Simple, start with single injection, continue metformin, DPP-4 inhibitor, SGLT2. Low incidence of hypoglycemia, less chance of weight gain. So these are the advantages. Disadvantage when you use basal, controls fasting, will not control postprandial, and you cannot achieve A1C of 7 with basal alone. Requires additional bolus insulin before breakfast, lunch, and dinner. When you use premixed insulin, it is simple to start, single injection, only 1 pen, and it can effectively control fasting postprandial, better A1C control, and you can intensify. You start with 1 dose, the same pen, same syringe, same insulin, you can go twice. Many times people use premix 3 times a day also. So what are the disadvantages? Slightly more chance of daytime hypoglycemia. Give dose in the night, he may get hypoglycemia in the night. And again, weight gain is more in these patients compared to basal insulin. This is how non-insulin regime, start basal alone. Then if it is well controlled, good. If not controlled, depending on which postprandial. After breakfast, high, give 1 mealtime rapid acting. Suppose after lunch is high, give 2. Suppose after dinner high, then basal plus 1, plus 2, plus 3. Start basal insulin, go on adding depending upon whether post breakfast, post lunch, post dinner is high, 1 or 2 or 3 doses of short acting. Whereas you start with premixed one, go to twice. This is our number of injections are here, 2 or 3 or 4, 1 or 2. Now, how to initiate insulin? When you start insulin, everybody asks a question, should I continue all the tablets? Let us assume patient is on sulfonylurea, patient is on metformin, and patient is on gliptin. you can continue gliptin and metformin full dose. That means 2 grams of metformin. And suppose you are giving the gliptin, whether it is vildagliptin 100 mg or whether you're using sitagliptin 100 mg, you can use. But if you are using sulfonylurea, reduce the dose to half. If you are using glimepiride, which is 8 milligrams, reduce it to 4 milligrams. If you are using glycoside, 60 milligram twice, 120 mg, reduce it to once a day. So metformin, gliptin, SGLT2 may be continued. If the patient is on metformin, gliptin, SGLT2, you don't have to stop anything. You continue all the three and start insulin, because many times people stop all tablets and start insulin. After 3 months, patient comes, doctor, previously my blood sugar is 180, 200. You are giving insulin once a day, it is 300. I don't think insulin working. Let me go back to tablet. So it's a mistake where doctor stopped all the tablets. Never stop all that. Pioglitazone, don't use it with insulin. But these three you can use, or reduce sulfonylurea half. Later on you can stop. So HbA1c is more than 6.57 or less than 8.5, and more than 1 at night, either NPH guarding 4 units. Fasting to postprandial, the difference between fasting postprandial less than 40. Somebody's fasting is 160, postprandial is 190. So that is less than. If the difference between fasting and postprandial, if that difference is more than 60, let us say somebody's fasting is 180, postprandial is 300. Basal insulin will never control, because even if 180 fasting comes to 100, 300 postprandial will become 220, not good control. So where the difference between fasting and postprandial is less than 40, please use the basal insulin. Whereas if the difference between the two is more than 60, you must use in such situation premixed insulin. That is why when the patient is on maximum 3 oral antidiabetic, look at the difference between fasting and postprandial. Then you can decide basal or bolus insulin. Then if the HbA1c is more than 8.5, if you use basal alone, you cannot bring it to below 7. 8.5, 9 or 10, then you have to use premix. But if it is between 7 to 8.5, you can manage with basal insulin alone. Now there are so many types of titration as such. This is one simple. Suppose the fasting blood sugar on 3 consecutive occasions is more than 100, less than 120. You have started insulin, then you can increase the dose by 2 units every 2 to 3 days. And if you see between 120 to 140, you can definitely give 2 units. 140 to 180 fasting, give 4 units. If the fasting, as I told you, 180 and 200, start with 6 to 8 units. So this is how you can titrate every 3 days. Maximum, I tell you, 2 to 4 units. Rarely when it is very high, more than 200, you can increase the dose by 6 to 8 units. Then check. Otherwise, start slowly, start with small dose, maybe 8 to 10 units per day, then go up to 20, 30 units of basal insulin. This is how you start larging 4 units, go up to 10, 20, till the fasting comes between 100 to 120. Then this is forced titration. Start with 10 units bedtime basal insulin, self-monitoring of blood sugar, and depending upon the fasting and all, you can increase the dose 100 to 120, increase 2 units, 120 to 140, 4 units, 140 to 180, 6 units, 180 above 8 units. On what basis? If you roughly take it, by increasing insulin by 1 unit, the blood sugar will come down by 10 units. So if the target fasting blood sugar is 10 milligrams more than the target, increase 1 unit, 20 milligrams more 2 units, 40 milligrams more than the target, then 4 units. Suppose you want to achieve 100 milligram fasting, the fasting is 180, you can give 8 units. This will always work most of the cases. Some patients may need less than that, some patients may need more than that. Assuming the target of fasting is in 100, you can use this formula of 2, 4, 6, 8, between 100 to 180 fasting. Then this is how we usually start. That we start when the diabetes is detected 6.5 and above, you start lifestyle modification plus metformin, go on adding that. Once the HbA1c 2 times more than 7.5 with 3 oral antidiabetic maximum, you start basal insulin, and the postprandial increases basal plus 1, and still it is high. Then you give basal plus 1 or 2 or 3 shots boluses. That is called basal bolus insulin, because At the beginning itself, 50-60% of beta cells are gone. By the time you reach this, you will see almost 90% of the beta cells are gone. Then patient needs 4 doses of insulin, 3 bolus, 1 basal. So progress is that. Remember one thing, that insulin is better than tablet to control. 2 doses of insulin are better than 1 dose. 3 doses are better than 2 doses. 4 doses are better than 3 doses. So if we remember that when diabetes is not controlled, more doses of insulin, more frequently you give, better control will be there. You have to impress upon the patient. And this is how the beta cell, when even 5 to 6 years before the diabetes starts, from 100%, by the time you detect diabetes, already 50-60% of the beta cell is gone. Lifestyle and OAD, another 40% gone. By the time intensify, hardly 10-20% of insulin is left in the body. This is where you initiate and you see how much of beta cell is gone. Then adjust the dose where you reach. Then add basal plus 1 or 2 boluses. Then you see how it goes. So even pre-mixed insulin, if you look at blood sugar, depending on the blood sugar, if the blood sugar is less than 80 postprandial, reduce 2 units. If the postprandial 80 to 110, no change. 110 to 140, increase 2 units. 140 to 180, 4 units. If it is more than 180, increase by 6 units. This is how, depending on the postprandial blood sugar, you can adjust the dose of premixed. Whereas basal insulin is only based on the fasting blood sugar. As I told you, there are various regimes, basal insulin plus OAD, pre-mixed with OD or BD, once a day, twice a day, or prandial insulin or co-formulation. So intensification basal plus 1, pre-mixed twice, pre-mixed thrice, basal bolus 4 times, or co-formulation twice. I still have patients they are using co-formulation twice a day. Of course, it is expensive, but you will have a fantastic control. You can depend when basal plus OAD to basal plus therapy, or premix twice a day, or you can go to basal bolus, or premix once to twice or thrice, or from premix twice to basal bolus, or prandial insulin to plus basal therapy. Various permutation combination I can see here. You can interchange. It is your discretion. After all, insulin is a tool. How you use the tool depends on you. How frequently use, how well you use it. That is why clinically you will be a successful doctor. And this is how we start with one regime on the left side, go to the other. These are all possible. See, all these. So advantages of basal plus strategy: help intensify early by adding rapid acting insulin to heaviest meal, overcoming clinical inertia with a stepwise approach to intensification. And this is what advanced type 2 diabetes basal bolus therapy reproduces physiological one. Throughout the day, blood sugar will be between 90 to 140 in a normal person. Every time you take a meal, the blood sugar rises, insulin rises, it will never allow it to see. When you give exogenous insulin, then this is what it is. This is ideal, not possible. Ideal postprandial, but at least before breakfast, lunch, and dinner, take bolus and 1 basal. You try to mimic that. This is what is true today. Initiating, how to start, how much to start. This is rough guideline. The minimal dose you start of insulin is 0.15 units per kg per day. Or if you are a little bold, you can start with 0.5 units per kg per day for replacement can be done. That means if a person is 60 kg, you can start almost 10 units per day, or you can start with 25 units per day. Very rare cases, you may start with 30 units. By and large, we start with 0.15 to 0.25. That means if a person is 60 kg, if your patient is 60 kg, you start with 10 to 15 units. Then go up to 20, 25, you may reach 30 units at the end of it. Then about 50 to 60% of total daily dose requirement should be basal type. Suppose you are using, let us assume you are using 30 units of insulin. So 20 units should be basal and 10 units should be basal. So this is how you can make the difference and use it. That is why you got 25-75 insulin regular is 25%, long-acting NPH 75, or 30-70 where 30% is regular, 70% long-acting. But during the day when you have a high carbohydrate meal, you can have 50-50 where 50% of short-acting, 50% of long-acting or intermediate-acting insulin. So ideal regime is basal bolus, 4 or 5 injections. And when you want very intensive one, insulin pump. But we cannot use basal bolus. If we tell patient I'll give one insulin, they are hesitating. If we say I'll start 4 times, they will run away, except in type 1. That is why a compromise is start with premix dose once a day. After 3 days, make it twice a day. And most of the type 2, 90% can be managed with split mix dose. Very few patient needs basal bolus insulin as such. Basic difference. Intensive regimen mimics physiological insulin. Provide 24 basal insulin dose of bolus insulin. Prerequisite for basal bolus. Selection criteria must be carefully applied, which includes highly motivated family, ready to check blood sugar regularly, and also affordability because the cost. Advantages of split mix is better glycemic control, fewer long-term complications. Disadvantages, expensive, commitment, family. In type 1, tell them, no, you want this child to be healthy, you have to give 3 or 4 times, they'll agree. Whereas type 2 diabetes will not have that much of the commitment. They say, I have managed 10 years, 15 years tablet, don't give me 3 times, let me start with 1 dose. So, all right, you start with 1 dose. How to intensify? What are the problems? If you intensify hypoglycemia, patient acceptance multiple dose, cost of therapy, monitoring doctor, I have to take 3 times insulin, I have to check 3 times. My whole time will be spent only looking after diabetes. Then next question is, doctor, all right, you say blood sugar. When I do blood sugar 3 days, how do I communicate to? Can you call you? No, I'm very busy. I have 5,000 patients. I don't want my patient to call me every day. Can I call your assistant? And also I get depressed taking so much psychological support. So these are all the problems of intensification. So that's why it is not easy in type 2 diabetes to do, but type 1, it is possible, it is necessary. Split mix or twice regime, low cost, fewer injection, and 2/3 of the total dose before breakfast, 1/3 before dinner. Most of the patient take 30 units before breakfast, 10 to 12 units before dinner, 2 doses, they'll be very well controlled also. Now, the question most often asked, sir, I had previously animal insulin, then we had human insulin, now we have unlocks. Is there any difference with that? Because animal insulins were cheap. When I started, it was 8 rupees per vial, became 16 rupees per vial. Then later on become 200 to 250 rupees per vial asset. Now I see that this is the cost. The cost is so high. If unlock, some of them cost one cartridge of 300 unit cost 1,500 to 1,800 rupees. So what is the benefit? Mealtime and meal size flexibility. The regular insulin, human insulin you take, you have to wait 15 to 20 minutes before you take meal. Whereas analogs, you take an injection, keep it on the dining table, you take injection, start meal. More physiological replacement, regular insulin, less hypoglycemia, better postprandial glucose control, better patient and parent satisfaction. It is ideally suited for subcutaneous insulin through the pump. Availability in insulin pens make insulin therapy most friendly. Most of the analogs today are available are pen. 99% of my patients use pen. They are scared to use syringe. That is why these are the benefits of analog. Are there any disadvantages? Yes. Because don't think that insulin analogs are superior to human insulin. Suppose you are giving 10 units of human insulin, when you change over to analog, use the same. Vice versa, when you shift from insulin analog to human insulin, same dose is same. Second is cost, 2 to 3 times they are costly. Availability, when you are a rural setup, sir, you have prescribed this analog, it is not available in my village or small city. And you have to use it in pen. Many of the analogs are not available with syringe. So these are the 4 disadvantages of analog, and previously I have told you 6 to 7 advantages of it. Now, we should know, once we know about insulin regimen, which insulin, human analog, the AD has set up a criteria for hypoglycemia. Level 1 hypoglycemia is defined as measurable glucose concentration below 70, but more than 54. This is level 1. Patient himself will know, he will take some glucose or food, he will be all right. Blood glucose concentration 70 milligram has been recognized as a threshold for neuroendocrine response to failing glucose in people with diabetes, without diabetes. So this is how you see hypoglycemia is classified as asymptomatic or biochemical, which is particularly common because many times patient is 65, he has no symptoms. Symptomatic or severe, which requires assistance of another individual. He may be drowsy, somebody may ask him to. or sometimes they are unconscious. You have to take into a hospital or give IV insulin, IV glucose, or even glucagon. So the best way to manage hypoglycemia is educate the patient about the symptoms, how to prevent. Suppose patient takes more insulin, he gets hypoglycemia. He takes same insulin, less food, he'll get hypoglycemia. Suppose takes same amount of food, same insulin, but exercises more, he'll get hypoglycemia. Tell them that we have to match insulin to your food, to your exercise. With this food, with this exercise, this the insulin. For any reason you are taking less food, please reduce the insulin. For any reason we are doing more exercise, reduce the insulin. And what are the symptoms, how to manage it? This is the study to see how all diabetics, type 1 and type 2, the amount of the hypoglycemia, whether it is retrospective or prospective, type 1 diabetics have highest typo because they use basal bolus. The next one is the type 2 and others if you put like that. So that is how, whether it is any hypoglycemia daytime or nighttime, again, nocturnal hypoglycemia more common in type 1 compared to type 2, and severe hypoglycemia is common in all if they are using that. So this is the difference between type 1 and type 2 hypoglycemia. The symptoms all of you know, that neurogenic, that is trembling, palpitation, sweating, anxiety, hunger and nausea. Then neuroglycopenic or difficulty in concentrating. Suddenly you say, sir, I'm talking something irrelevant. Yes, you had hypoglycemia. Confusion, patient in confused where I'm standing, weakness, drowsiness, blurring of vision, difficulty in speaking. If you still leave it like that, severe hypoglycemia, he may become unconscious also. The main cause is too much of insulin or sulfonylurea, exercise without adequate food. So tell type 1 diabetics, when you go for exercise, please take one snack and then go. Skipping meal, patient takes insulin. No, I'm not hungry, let me have one cup of milk and then go to sleep. You'll get into hypoglycemia. Lack of glucagon and long time hypoglycemia unawareness, because glucagon is one which is available from the alpha cells. If the alpha cells are not working, glucagon is not there. That's why they are exhausted. Excess of alcohol intake. If patient takes excess of alcohol, takes sulfonylurea insulin, it can also cause hypoglycemia. Apart from diabetes, insulinoma. Somebody is not even diabetic getting sugar, you should rule out insulinoma acid. What are the risks? Endogenous insulin deficiency, history of hypoglycemia, unawareness. This is what most of the patient get symptoms when it is below 70. But chronic diabetes, autonomic neuropathy, sometimes I see my type 1 diabetes, blood sugar is 30. Uncle, I am all right, I don't have any problem. This is the most dangerous thing, hypoglycemia, unawareness, because the autonomic neuropathy occurs. There is no sympathetic response at all, no palpitation, no sweating, no hunger. Suddenly patient may go into unconsciousness. And if the patient is in sleep, again, this risk of hypoglycemia is dangerous. Renal failure. And this is one where patient is getting 40 units, he gets hypoglycemia 30 units, he gets 20 units hypoglycemia, 10 units. Patient says, doctor, I stopped insulin 1 month back. See, my blood sugars are well controlled. Patient is very happy. I think my diabetes has disappeared. No, it is worsening. When there is a sudden decrease in insulin dose, please look for renal failure. That could be the cause of hypoglycemia. Monitoring diabetes, you should know. You should monitor fasting, postprandial A1C, or even ambulatory glucose profile. You can measure capillary blood sugar glucose meter, venous in the lab. You have got glucose meter. Don't call glucometer. Glucometer is a trade name of a company, MX. Either you call it as glucose meter or reflectansometer. When to check? Best time I ask my patient to check at home, fasting when they get up, before lunch, before dinner. Why? The night dose decides the fasting. If the night dose of insulin is all right, fasting should be between 90 to 120. Morning short-acting decides pre-lunch, that should be 100 to 120. Afternoon insulin decides pre-dinner should be 100 to 120. If hypoglycemia occurs, either it's midnight, early morning, before lunch, before dinner. That's why I always ask my patient to monitor fasting, pre-lunch, pre-dinner, or pre-meal blood sugars. So an approach whereby diabetic patient measures blood sugars, that is glucose meter. Based on the reading, patient can himself adjust the dose. That is why self-monitoring diabetes, self-management is very important today. So when the patient is on insulin pump, the recommendation is at least 4 blood glucose per day before breakfast, lunch, and dinner you have to do. Persons with diabetes treated with single insulin dose, at least 1 blood sugars per day, he can stagger it. Today he can do fasting, tomorrow he can do before lunch, day after tomorrow before dinner. Persons with type 2 treated insulin secretagogue, at least when he has hypoglycemia, because patients who are on tablet need not monitor daily. You cannot adjust the dose. If he has symptoms of hypoglycemia, you can manage. Persons with type 2 being treated with anti-diabetic medicines, no hypoglycemia, you don't have to buy a glucose meter because many patients become hypochondriac. They are on only diet or one tablet, metformin. They go on doing the blood sugar. Doctor, one sugar is 180, I'm worried. So I never advise my patients on tablets, and especially if they are orthosulfonylurea, I don't ask them to buy. Even if they are meter, I don't ask them to monitor. Patients who are on secretagogue like sulfonylurea, 1 dose, 2 dose, 3 dose pump, only them I ask to monitor. This is the recommendation, how frequently. One simple word, as frequently as possible if we are multiple dose. All of you know about AGP flash meter. You attach it like a 1 rupee coin, 24 hours it gives 90 blood sugar. In one of the futures technology of diabetes, we'll discuss more about flash glucometer. And this is how you see this patient, blood sugar is going up to 180 morning and even 200 in the evening, and he had 6% hypoglycemia. And you see here from 13th May to 8th June, when I adjusted the dose from 186 average blood sugar per day came down to 114, and above range TIR, that is time in range above this 180 was 6%, sorry, 29%, and it has gone up. I mean, this is the time in range was 29% here, and it has gone up to 87%. So time in range should be above 70%. So mean was 186 came down to 114 in hardly 20 days, and time in range was 29%, increased to 87%. Time below range was 6%, but increased to 11%. And if we see time above range, which was 65%, has come down to 2%. So by using ambulatory glucose profile, how within 15 days adjusting dose every 2 days, you can bring down the mean to good and time in range from 29 to 87. But when you try to achieve, of course, hypoglycemia will go up, but hyperglycemia has come down significantly. Everything is good here except slightly increased hypoglycemia in this. We'll come to that later on why. So if you see insulin delivery system, first, exactly 100 years back, 1921, then you had discovery of insulin syringes. Then disposable syringes, 54, it took 40 years. Then pump was there, 63. I started using pump from 1985. Then commercial pump was there, 79, 6 years after introduced. And you got that many of the insulin second generation pens, and then ambulatory glucose monitoring, all these we have come, and today you have got a closed loop system known as artificial pancreas, and that is the one which is ultimate, that the basal, you fix that blood sugar between 80 to 140. As soon as blood sugar comes to 90, pump will be up. As soon as blood sugar goes up to near 140, pump is on. So you don't have to worry about the basal insulin. You just have to calculate for breakfast, lunch, and dinner how much of bolus insulin give dependent on the carbohydrate count. So we started with the syringes. You should tell your patient know that there are two types of the insulin syringes. One is the red, where it is U40, and the other one is orange, where it is U100. So 0 to 40, this is U40, 0 to 100. Patient should not use U40 insulin, U100 insulin, and if he uses U100 insulin, U40, both will be disastrous. So teach him for U40 vial, you must use only U40 syringe. For U100 vial, you should use U100 syringe. Now we have got insulin delivery systems, which are more accurate, convenient, better compliance, you can carry away. Newer pens will have LCD display. When you just inject, it will show how much of insulin. J setting is very quick. Safety button automatically, once you push, it comes back to 0 also. Then you will have an app where you will see once you take insulin, that whatever amount of insulin patient has taken automatically goes to the app also. So ideal pen, dose accuracy, durability, convenience, and safety. These are the most important things when you use. Benefit of pens is less doing errors, dosing errors is less, because in syringe you may have 2 to 4 units error as well. And somebody who is blind, cannot see that, so you will have click 1 click, 2 units, 2 click, 3 clicks like that. So breakage is less, portability is easy. Adherence to therapy better, acceptance is better, better control. Overall, in the long term saving, eco-friendly, because if every day use 1 syringe, 2 syringe, and hundreds and thousands of syringes, if millions of people are using that, so that's why pens are eco-friendly. Of course, this is a pump where a pump reservoir is there, small battery operated computer chip. You can program it 24 hours, morning 6 o'clock to night 8 o'clock, 2 units per hour, evening 8 o'clock to 6 o'clock, 1 unit per hour, bolus 4 units before breakfast at 8 a.m., bolus 6 units before lunch, bolus 4 units before dinner. You fix everything and better quality of life. This is how pumps, what you see prototype. This was the pump in 70s, so big, and then it became huge. And ultimately, you see small, it is as big or even smaller than your mobile phone as such. This is how the pump evolution has occurred from 1960 to here. When I used the first pump in 1985, that was my fuser Japanese pump, which is as big as my hand. It was costing 10,000. Today, you see these pumps costing 5.5 to 6 lakhs rupees with sensitive expense. To summarize my talk, early insulin therapy will preserve beta cell function. Early intensive therapy is necessary to prevent microvascular, probably macrovascular complication. Normalization of glycemia, that is A1C below 7, should be the goal of insulin intensive therapy, avoiding clinical hypoglycemia. Insulin delivery devices like insulin pens are more acceptable to persons. So insulin remains the most powerful agent we have to control diabetes. Initiation to intensification is essential to achieve A1C target who need insulin. Both basal premix insulin are useful in initiating. Insulin pen devices are user-friendly, easy to administer, compliance, and acceptable. Basal insulin useful in high fasting and postprandial, not very high from fasting. If postprandial is high, start premixed insulin can increase up to twice a day. Thank you for your attention. I'm sorry I had to take a lot of time because this is a very big module with almost 70 slides. You cannot reduce it to 30, 40 minutes. I have taken 50 minutes. We still have 10 to 15 minutes. If you have any questions, please put it in the chat box or unmute yourself, open your video. You can ask directly. We can extend it another 10, 15.
Thank you so much, sir. So we'll take a few of the questions now. So the Dr. Krish wants to ask, if the patient is already on insulin since years, can we try new drugs to stop insulin?
Yes, it is possible. See, you should remember, if the insulin requirement is less than 20 units per day, if patient is taking 30, 40, 60, 80, 3 times, no tablet is going to do. If the patient is taking 20 units of insulin and blood sugars are well controlled, let us say you usually metformin and you are using gliptin, you can add SGLT2 inhibitor. When I've added SGLT2 inhibitor, the insulin dose came down to 12 units per day decrease. Suppose you use GLP-1 analog and patient loses 3 to 6 kg. Again, 14 units of insulin have been reduced. Next year, we are getting semaglutide. When semaglutide was added to the therapy, 12 to 14, even 20 units of insulin reduced. My thing is, if the patient is on insulin less than 1 year, if he is taking less than 20 units per day, you can start reducing insulin, add the third drug if you are not used, or GLP-1 log oral or this, you can definitely fix. Suppose it does not work, go back to that. Look here, I was giving 2, I have given 3, reduced to 12, 10, 8, sugar has gone up to 200. I think it's working. You continue 3 types of oral anti-diabetic. I will increase it to 16. You cannot go on doing this. Patient is happy. Doctor try to stop. Many times we have seen that patients who are taking even twice a day, 10 units have stopped. It may happen 3 months, 6 months, again he may need insulin. So you can use, provided it is small dose, once or twice a day. Large dose, 3 times, don't try that.
Hello?
Yes?
Yes, sir. So the next question we have, sir, what is the time frame of taking insulin before meals? If you forgot to take it before eating, can you take it during or after the meal?
Yes, as I told you, the insulin analogs can be taken even up to 10-15 minutes after food. Let us say patient is taking human insulin. It is better to take after food rather than not at all taking. If you miss that, next 2-3 days blood sugar is high. And in especially children, lot of mothers say, I am not sure the child will eat that much of food or may vomiting. They may give it even 5-10 minutes after that, like aspart, do lysine, lyspro can be given after food. Basal insulin can be given anytime. Suppose you are doing Largin or Detimer or Degludec, you can give it before food, after food does not matter. Only thing is give same time of the day. Suppose you are giving morning, tomorrow also give morning, whether before food, after food does not matter. Whereas Degludec can be given, suppose you are given today morning, tomorrow morning you forgot, you can give it tomorrow evening also because it will work even up to 36 hours. You can give it better late than never.
Right, sir. Thank you. So the last question will take, sir. I am in the pre-diabetic zone and recently started taking metformin, 500 mg twice daily. Why is my fasting blood sugar going up in spite of the medication?
So metformin alone. So don't go by HbA1c alone. It all depends upon technique and all. If the metformin is taken, suppose you are 500, you are on 1000, the fasting is high, please go up to even 2 grams. In spite of going up to 2 grams, if your HbA1c is still not below 7, and if the fasting is still high, you have to use another drugs, which will bring it down as such. So start 500, go up to 2 grams metformin. You need not have to stop 500 once or twice a day. Make 1000 morning, 1000 day. Still the fasting is high. You have a choice to add another one, DPP4 inhibitor, that if you take gliptin once a day, the fasting may come down. If not, if you are overweight or if you have this, you can even use SGLT2 inhibitors, one tablet, it may bring down fasting. Suppose the gliptin, SGLT2, metformin, all of them have not brought down your fasting below 120. You can state a small dose of basal insulin that will definitely bring down your fasting blood sugar.
Right, sir. So thank you so much, sir, for your time, for taking us through the pharmacological management of diabetes. I hope these queries will be helpful to all the doctors to have everybody into their day-to-day practice. So thank you so much, sir, and thank you all for joining us today for the